So two presenters, Dr. Mary Bayat, who's a cardiologist specializing in advanced heart failure and cardiac transplantation. Very dedicated in so much that Mariam is presenting from clinic in between patients. Thank you, Mariam. And secondly, Dr. Kanti Vemuri, who's a transplant ID physician that we're very lucky to have on our team. Kanti trained in infectious diseases at the Royal Brisbane Hospital, Prince Charles, and Sunshine Coast University Hospital, but spent a lot of, spent a year at University of North Carolina as a transplant ID fellow at a center where they do up to 400 transplants annually. Kanti's introduction to our team led us to think about developing a dedicated transplant ID service, and we're just taking a few steps in that direction. Now, this next talk has a hospital-specific context in that we seem to have a higher rate of invasive fungal infections in our heart transplant patients within a short span of time. By definition, a cluster, which proved not to be an outbreak eventually. But what it did do is force us to really look at our historic rates, what the pathogens are, and what are the implications of various prophylactic strategies. So thank you, Kanti and Mary.
Thank you for the introduction, Alex, and thanks for the this opportunity. And I'm hoping Mary is online.
Hi, Kanti. Yes, I'm online.
Yeah, hi, thanks, Mary. Today I am going to talk about, I think it's a very good timing, because I think the whole of the morning has laid a great foundation for my talk. So I don't think I have to kind of, harp on about the same points. Like the first talk on the liver transplant about the, questioning about the utility of prophylaxis, and then developing guidelines by the nephrologist Samantha, which is so exciting, which was a part of what I did, and then Cassandra talking about the azoles and how to choose an azole. So it's going to be, so that's actually been is going to be my talk, like is the evidence and guidance behind the antifungal prophylaxis in heart transplants. And if people in the audience are thinking, but there's none, you're absolutely right. But then you have to decide whether you're going to do antifungal prophylaxis or not, if you're working very closely with transplant patients like me all the time. So I'm not going into too much on this, but invasive fungal infection is a very frequent and dreaded complication. Most of the international large registries have said, have data up to a quarter of the patients will have an IFI, and most commonly in the first 90 days. And the most common pathogens being Aspergillus and Candida, as we know. So what is the main aim of prophylaxis? Is to prevent the colonization, and then if there is, then to prevent infection, and for that to spread systemically or even cause disseminated infection. We have evidence from the bone marrow transplant and lung transplant that antifungal prophylaxis does work and can decrease the incidence and mortality. But it is not straightforward, because as we know comes the flip side of antifungal prophylaxis, which is it decreases the fungal diversity, which is going to change the microbiota. And there's huge research and learning around the microbiome and the commensal pathogens causing infections, emergence of resistance, and then also the decrease in the performance of the fungal diagnostic tests when you're on the azole prophylaxis, and the multiple drug-drug interactions. So it all ended up like a toss of a coin. There is guidelines, there is suggestions, but then you're always stuck there to understand how to do this. The International Society for the Heart-Lung Transplant, as well as the American Transplant Society, says make your own plan, targeted prophylaxis, look at your centers, and then decide as to whether you think your patients need prophylaxis or not, which is then going to cause a lot of confusion, because it's a very individualized approach by all the centers all across the world. And then again, that is led by the geographic location and their own local epidemiology, or whether they've had any fatal cases within their heart transplant program. So I am not going into many, many papers here. I think I chose the papers that the guidelines have chose to give us any advice. And one of the basic foundation papers is this one in 2004, which was a study designed to identify a subset of heart transplant recipients who could benefit from targeted antifungal prophylaxis. And then they were assessing the efficacy of oral itraconazole, because as we've just learned, itraconazole has lesser drug-drug interactions. So they had 278 patients in this study, but then 24 cases developed invasive aspergillosis during the time that they did. It is a single center retrospective study. All of them had Aspergillus fumigatus, and the itraconazole prophylaxis kind of lasted between 60 days to 159 days, again, highlighting how there is no guidance around for how long should you be doing the antifungal prophylaxis. What they found on their multivariate analysis is that reoperation, CMV disease, post-transplant hemodialysis, and having another case of invasive aspergillosis within the heart transplant program 2 months before or after the transplant date was associated with a high risk of development of invasive aspergillosis. And then in the itraconazole prophylaxis arm, they found that being on the prophylaxis actually reduced the risk pretty significantly. This is another graphical way of them showing that the Cox, with the Cox regression probability graph showing time free of invasive aspergillosis in patients on itraconazole prophylaxis, which is the gray line on the top, as well as those not on antifungal prophylaxis. Again, the limitations, as you all know, is the unicenter historical cohorts, very small sample sizes. But then there was this noise coming that heart transplant patients can benefit from antifungal prophylaxis. The other study was this study done again to check the targeted antifungal prophylaxis in heart transplant recipients. And this center actually embarked on antifungal prophylaxis after they have had 2 cases of invasive aspergillosis in their heart transplant program. And then again, they used echinocandins because there is some in vitro activity of the echinocandins against the molds. And again, they have demonstrated that there is a difference between infection-free survival as well as overall survival in heart transplants based on being on prophylaxis and not being on prophylaxis. But again, disclaimer, the sample size was very small. It was 26 patients versus 54 patients. Then the first group, the Munoz et al., used their information about the risk factors that they found in their first center to kind of, again, revisit and then do targeted antifungal prophylaxis with echinocandins in their transplant center by using all the risk factors, such as the reoperation, CMV infection, hemodialysis, and also another patients with invasive aspergillosis, and started doing the using caspofungin. And what happened was during their study, they actually did have a high aspergillus spore burden within their intensive care unit. So all their transplant patients were being exposed. So they felt that despite that, they did not see any high mortality, and they attributed it to the echinocandin prophylaxis that they were doing at this time. So the evidence, again, as there are many, many other studies similar to these ones, single center, retrospective, small sample, uncontrolled studies. And even in some studies, there was issue about the intensity of immunosuppression, the geographical location of these centers, whether pre-transplant colonization was checked. And then at times, there is some imprecise criteria in definitions of fungal infections as well. So is there any efficacy of the prophylaxis? Again, is still a question, because as we know, it comes with a lot of side effects, drug-drug interactions, rejection, again, augmented immune suppression, loss of graft function. And, most of the patients die because they're often very critically ill. Is that because it has nothing to do with the efficacy of the prophylaxis or just starting with a critical illness? Based on all this, the International Society for Heart-Lung Transplant have come up with their guidelines, which for heart transplants, which says consider targeted antifungal prophylaxis if your patients have any of these, which starts with airway colonization with aspergillus, reoperation, post-transplant hemodialysis, need for ECMO, CMV disease, and development of invasive aspergillosis in any patient within the heart transplant program 2 months before or after, and the presence of aspergillus spores in the ICU in which the heart transplant recipients reside. So this is where all the risk factors came, and they said they leave it to the centers and the individual transplant programs to do a risk stratification of your program and go from there. The problem I find with this kind of guidance is that most of the centers don't routinely screen patients for airway colonization with aspergillus, and then reoperation, post-transplant, hemodialysis, ECMO, CMV disease are things that develop after the transplant, and sometimes you will not be able to actually anticipate which patient is going to need all these or none. And then the presence of the aspergillus spores in the ICU. Yes, we are all meant to keep constantly surveilling, but then again, by the time that happens, it's not as standardized as we think. And then the development of invasive aspergillosis in the heart transplant program is something very, I think, something doable by having a systematic close infection surveillance within the program. So as Alex just mentioned, as in August, we found that we've had 3 cases within our heart transplant, very close to their transplant dates, and had aspergillus, invasive aspergillus infection based on the new criteria, and they were all probable, definite actually, eventually by the time we also got the cultures. And this prompted us to think about what we were doing within the heart transplant program. Our routine universal prophylaxis up until that point was nil-stat, 1 to 2 mils from extubation to until their prednisone was 20 milligrams a day, and nebulized amphotericin from day 2 until they were discharged from the hospital. So we had concerns. We were unclear about the evolving clinical situation, obviously worried. And then so we immediately started having our meetings and then put in place surveillance strategies to understand what, the patient's journey in the hospital. But I think the most important thing was the concern for patient safeties who's had transplants around that time and who were going to have transplant. So we were battling about the universal or the targeted prophylaxis. How did we make the decision? And I think it highlights the multidisciplinary approach. We had a lot of conversations among ourselves, literature reviews, multiple meetings, input from us as a team, like, infectious diseases. I've just started my job there, so I was very, lucky that I had all my team co-physicians helping me and guiding me as I was coming up with ideas. Cardiology had immensely on board, and the pharmacists, transplant coordinators, and infection prevention nurses. So we decided to put all the strategies at the same place. So there were multi-pronged approach happening. And then we decided to go with universal prophylaxis. Again, because there was evidence both for azoles and echinocandins, we had lots of discussions among ourselves, not just about the efficacious approach, but the drug-drug interactions, but also the pharmacoeconomic approaches. We had a lot of discussions, and then we've decided to actually initially start with posaconazole, but over the span of time, as we were going ahead with posaconazole, we had 2 cases which had possible fungal pathogens which may not be susceptible to posaconazole. So we decided to go with voriconazole, and then we came up with this guideline for our heart transplant program. And a shout out to Olivia Stanton, who's the heart transplant pharmacist, and Cass, who's sitting here, for coming up with this guideline and helping to do all that flow chart. So what we did was, as you can see, everybody went on nebulized amphotericin, and then by day 2, if there is an oral route available, we did oral, they would go on oral voriconazole, but if not, we did do IV voriconazole. Because at that point, we didn't know what we were dealing with, whether this was actually an environmental clinical issue within the hospital or not. We felt like we have to continue the nebulized amphotericin until we get the therapeutic levels of the voriconazole. And then we are going to continue all of them for a minimum of 3 months. And then at 3-month mark, we would review every individual patient with their risk factors and decide whether we need to continue or stop. So my takeaway from all this experience was that this is not a straightforward decision. There is not much evidence there, just like for any other transplant infection diseases prophylaxis question. But what needs to happen is like we need to take into multiple factors. Pre-transplant screening is important because that's what we felt. We were not sure about what kind of lives the patients had before coming into the transplant. Was this pre-transplant colonization then getting reactivated or not? So, getting that detailed history for all the patients who have been listed, taking into account all the comorbidities and also the environmental factors such as the geoclimate, if there are any construction work happening around, and also making sure that all the HEPA filtered airs are maintained up to the standardization by closely working with the BEMS. So it's a very it's a decision and ongoing surveillance that's needed for every heart transplant program. My conclusion from here, or learning, I would say, is that this is still an unsolved question. There is no standard consensus. Yes, like always, we would all love to have some additional randomized studies, but I don't think we will be given the severity of these infections. And so if the takeaway points from this talk for today would be that pre-transplant infectious diseases screening and also counseling the patients about their risk to not engage in certain activities which will increase their fungal colonization is important. And then the transplant programs to incorporate active infection surveillance, which needs to be, again, standardized. And then environmental monitoring needs to be a very crucial part of the transplant programs as well. At this point, I think Mary is going to talk to us, and I think making the decision was one part of this entire thing, then making sure that that is incorporated, and how they had to do so much of therapeutic drug monitoring for immune suppression, checking the azole levels, needed a concerted effort from coordinators, pharmacists, clinicians being available. And so Mary is going to give us some more insight into that.
Thanks, Kenti. Hello, everyone. I'm Mary Bayat, one of the transplant cardiologists from Prince Charles Hospital. Thanks to Dr. Chowdhury for the introduction, and thanks for giving me the opportunity. Sorry that I had to join online. So today I want to briefly take you through our experience with antifungal prophylaxis in our heart transplant patients. As said before, there is no worldwide accepted consensus for antifungal prophylaxis in heart transplant patients. We had an old protocol of nebulized amphotericin and Nielstat, and for patients with a pre-transplant left ventricular assist device, we used to give a minimum of 1 week IV fluconazole. Then, given a cluster of invasive aspergillosis in mid last year in our heart transplant recipients, and also an ongoing environmental risk of construction on site, we moved to a new protocol of azole prophylaxis. Between August 23 and April this year, we had 14 new heart transplant patients. Also, we had 2 patients with acute rejection that, given the heightened level of immunosuppression for treatment of acute rejection, we started them on azole prophylaxis as well. This is the protocol that, after multiple discussion with infectious disease team, was adopted, and Kenti nicely explained that. We're aiming for a post-fluconazole level of 0.7 to 1 milligram per liter prophylactic level, and voriconazole level of 1 to 1.5 milligram per liter. We'll check the first steady level at day 5 from the commencement of the azoles. And then we are aiming for a duration of minimum 3 months, but we have extended that to 6 months given the ongoing environmental risk. We check the azole level and immunosuppressant levels twice weekly. And I want to give a shout out to our transplant coordinators. They spend hours daily to chase up the levels and then adjust the doses. So this is a great team effort. And also we are holding monthly azole meeting with infectious disease team, transplant coordinators, pharmacists, and transplant cardiologists. What challenges we faced? As nicely explained before, there's significant drug interactions between azoles and immunosuppressants, both calcineurin inhibitors and mTORs. The usual immunosuppression regimen that we use in our patients is tacrolimus, mycophenolate, and prednisolone. Since we started this azole prophylaxis, we had to start patients on a much smaller initial dose of tacrolimus with a very gradual increase. And sometimes we just increase the dose of azole and we don't change the dose of tacrolimus. There's a high risk of rejection at the time of ceasing or changing the dose of azoles because there will be a drop in the tacrol level. So at the time of ceasing azoles, we decided to escalate the dose of tacrolimus by twofold. There's a high risk of acute kidney injury through increasing the CNI levels. There's also interaction between azoles and calcium channel blockers such as diltiazem and verapamil that we use in our transplant patients that can result in hypotension. There's also interaction with NOACs that some of our patients need them, so we have to change it to warfarin instead of oral anticoagulation. Azoles can cause GI upset, nausea, anorexia, and weight loss. They can cause liver enzyme derangement. There is a significant ability of azole and CNI levels given no linear or proportionate pharmacokinetics. Azoles can result in QT prolongation and rarely can cause critical arrhythmia towards the point. Therefore, we need to regularly monitor ECG. Voriconazole is also contraindicated in the context of pre-existing long QT or in patients who are already taking another medication that can prolong QT interval, such as amiodarone, domperidone, or methadone that we use in our transplant patients. And there was also some patient compliance issues with twice weekly blood tests. In summary, given the above challenges, we had 2 patients with significant weight loss of 20 to 30 kilogram over a period of 1 to 2 months on voriconazole. One of the patients was intolerant of voriconazole because of significant liver enzyme derangement, anorexia, and nausea, vomiting. 2 of our patients developed acute rejection secondary to labile azole CNI levels. We had 2 significant acute kidney injury requiring admission. On the positive side, we had no further IFI since November last year. Thank you.
Thank you, Mary and Kanthi. Questions, please?
Thanks. That's really interesting. I noticed a couple of, they built this new cancer center next to the Alfred, right out the back of the ICU. And just, I was on ward service around that time and noticed a few fungal cases. Was there construction happening? Like, do you think that might have been part of it? Like, you guys got any development going on or?
Yes, I think there was a construction going on, but and it was they were building a car park and it was further down the road, but it was a major project. So, and that's what made us really take this on because it's an ongoing risk factor, as you know, and we felt like universal prophylaxis was the way to go.
Although the annual incidence.
Yes. So, yeah, in the hindsight now, at that point we were worried, but in hindsight now that we have more information and we are also looking into what IFI rates were in the past, it's been the same.
Yeah.
It was just a little closer, and that's what we kind of went on that. And this is all, as Alex mentioned, has kind of got us into doing some research with Angus, going to do a study on our heart transplant patients and how our IFIs were in the last 10 years and, looking into all that now.
And what about the lungs? They must be co-located with each other, right? Like
Yes, the lungs were fine. So, and then they were already on universal prophylaxis at our center with nebulized amphotericin and caspofungin. So we think
that's our best explanation.
Yeah. We do have Yes, yeah. Yeah. I mean, because again, there was no guidance for heart transplants and we were, chugging along, and that was the first time. And that's why we continued nebulized amphotericin, didn't take it out because our taking the information from how our lung transplants were behaving. And that's why it kept that in the protocol until we got therapeutic levels for the worry.
Yeah.
Yeah.
And final question. It's sunny Queensland, right? Like SCCs must be a problem in these people. Like, is that a factor in your decision making?
Yes, so that's why we went for POSA first, because taking that into our account. But then we've had certain pathogens which we felt worry is the way to go. But we're going to revisit our guidelines again, given with all the environmental surveillance information that we have now, and revisiting the construction. And then that is a very important factor for our patients, and we were very well aware. But we were doing a lot of education to our patients and about sun protection. But that's the reason why we went POSA first. But then we had to change again because of the changing epidemiology, again, being Queensland and the kind of molds we have.
Thank you.
Thanks.